Has everybody had time to check out the minutes, and if so, can I get approval of the minutes of last time's meeting?
So moved.
All second. All in favor?
Aye.
Opposed? Carried. Dr. Anderson?
No, that's me.
That's you, okay. Karen's gonna do the...
Dr. Anderson's just getting back from vacation, so I think he's a little bogged down. So I'll go ahead and give you a report. We have actually 2 medical staff meetings, both March and April here. So on March 12th, medical staff met. Adam Porter, one of our pharmacists, gave an educational presentation on antibiotics for the medical staff, kind of was extended by antibiotics. Let's see, we had a Zoom presentation from Signify Health ACO. Gave a kind of a refresher course to the medical staff on HCC or diagnosis coding for the medical staff. We had some revisions to our routine orders for our OB patients for postpartum hypertension, and medical staff reviewed those and approved those changes to those orders. Just to let the medical staff know, we do have some changes in our nursing staff. So Nicole Olinger is our new surgery nurse manager. She was also our outpatient specialty clinic nurse manager, so she's going to do both departments now. And then Kim reported that Claire Cron's new full-time nurse is Courtney Hansen. Jill Magus gave an update on general surgeon and family practice. Christy reviewed the financial statements. Also noted that Change Health had a cyber breach and kind of reviewed all of that with the medical staff, and also reported that we are now starting our budget process for the next fiscal year. Mary Peterson said there was a kickoff from the University of Iowa for a new program, DAX. Steve Finn gave a presentation on bone health optimization to the medical staff. And then we also handed out some information to the medical staff on physician and their contact information from CHI Health for interventional radiologists. So we do have interventional radiologists who come here, but if we needed additional services, we can also refer to them. And then on the April 9th meeting for the medical staff, Laura Friend discussed the ACO measures. Hospice had some revisions to their standing orders, medication changes. We reviewed symptoms of measles. There have been measles reported in a lot of surrounding states. So went over that with the medical staff so they could recognize measles, and very highly contagious. So that has to be reported to the state department right away before the patient even leaves the clinic. So we just went over some of those rules. Bryce Jagger from Information Technology talked about cybersecurity, that being heightened at this time. So we're looking at remote access into the system. So if you're not here at the facility and you're remoting in, and how to make sure we tighten that down. Carrie Sonderman from radiology came and talked to the medical staff about calcium scoring exams and how that will change in the future. Dr. Erlbacher had a request for lung cancer screenings and to kind of the process we go through for that. So Carrie said she'd look into that more. Jill again gave a recruitment update. Barry gave his updates, which I know he talks to you about. Christy again did the financial statements and updated on that Change Health breach. Talked about our Medicaid direct payment program. So unless there's any questions, those were the 2 medical staff meetings.
Is that breach pretty much resolved now? Did we get that all kind of fixed up and moved on?
No, it's not resolved yet 100%. They are still trying to recover a number of their systems, and they continue to work on the security and everything on it. The claims payments, I believe, a couple weeks ago were started on a limited basis, and I haven't heard that they have opened that up to everything yet.
No, so we're still filing our claims through a different vendor. We could technically take them back to them, but we're going to get through this a little bit. Our remittance are all being posted manually, which is a huge lift, but we're afraid to switch them over because then you're going to be dealing with 2 vendors down the road if the insurance company recoups some money or if there's a problem with a denial or something. So we're pretty much in a manual state right now, posting payments, which takes a lot.
Do we have any insurance coverage for that, like the additional timing? Do we go back to them to get any of that, recoup any of those costs?
We had asked that, I don't believe we do, but I don't have a definitive answer either.
Yeah, we did talk with our cyber carrier right away. Actually, I think we talked to the broker, and so we have coverage, but not for
Not that.
not for
That third-party vendor part.
Right.
Okay. Go to the next bullet here, quality improvement report by Laura.
Okay, our last system-wide QI meeting was on March 20th, and we had 15 departments that reported that day. Behavioral health was evaluating no-show rates and care coordination for the substance abuse program. They also are really kind of looking at patients that haven't been seen in the last 6 months, and that they're getting some type of communication from the behavioral health department to either be seen or and that the business office has evaluated hospital billing and professional billing timeliness. That was before kind of the issue with the change. Those were all good data. Public health reviewed departmental satisfaction, which was 97%, and learning for life goals. They're wanting the families to develop their own new learning for life goals. Diagnostic imaging monitored CT scan, the dual steady, and breast cancer and imaging reject rates. So how frequently a patient needs to be called back into the department to have a test redone. And all of those are in line with the state and national averages. Environmental services evaluated compliance with sharp container disposals, and they're also looking at a whole new system for disposal of needles. Human resources evaluated employee engagement, and they're doing a lot more of staff check-ins after hire and just following up with new hires regarding retention and evaluating that information. Information services reported on timeliness of IT ticket completion. Medical records looked at ED documentation, which was all very good. Emergency room department reported that from the time a patient arrives to the emergency room to the time the provider evaluates them, the average for that is 24 minutes. And after they're decided, if they decide to admit the patient, from the time they go from the ER up to med-surg is about 28 minutes. So it's really good numbers there. Medical surgical department monitored fall risk, completion, pressure, ulcer screening assessments, and hospital follow-ups, and those run about 98%, that those patients are all followed up in about a week to 2 weeks after hospital discharge. The birthing center had no early elective deliveries and also monitored OB and newborn complication rates, which are also no different and less than the state and national averages. Pharmacy reported no adverse drug events and no hypoglycemic events, and the rural health clinic reported on their ACO measures. We reviewed the full year for 2023, which were very good, and I said at a couple meetings, but we had an in-person meeting with Georgia from our ACO, and we were kind of at the top for our quality measures, like across the entire ACO. So the breast cancer screening rates, the colon cancer screening rates, depression screening, all of those quality measures. So we had really good information coming out of there as well. So that's all I have, unless there's any questions.
Any questions for Laura? If not, we'll move on to the approval of the Personnel Committee report.
The Personnel Committee met this morning at 11:30, and we have 10 initial appointments and 12 reappointments, 1 voluntary withdrawal. And I'll make a motion to approve those.
I'll second.
I have a first and a second. All in favor?
Aye.
Opposed? Motion carries. And next we'll go to, looks like a consideration of capital purchase by Jason Eckerman.
Yep. Well, anyway, I'm Jason Eckerman. If you don't know who I am, I'm the lab director here. I'm here to hopefully get approval for purchase of the new chemistry analyzer. The one we have currently is 6 years old. We were on a 5-year contract. We extended it out another year, so we're into the 7th year now. So I'll just start from there. So What I'm proposing is to purchase the Abbott Alinity. It's a fairly new analyzer, but there's several in the United States. There's not a lot of them around here, but it has one of the highest turnaround, or fastest turnaround times. It's capable of doing the high sensitive troponin, which is big for cardiac testing in the ER. I know the doctors are pushing for that, and Jenny Lefebvre goes to a lot of meetings about cardiac stuff, and she's really wanting it in the ER, so. Kind of hard to read. It has more Six Sigma assays, which is a process improvement for lab, which means basically it eliminates errors in testing. It has one of the fastest turnaround times on the market. It has no biotin interference, which biotin is it's part of the vitamin B family. A lot of people take it as a supplement, so it can interfere mostly with thyroid testing, and they do not have interference through biotin, which is about the only analyzer on the market that doesn't have some sort of biotin interference. No sample carryover, which means basically it's, it'll sample one patient and then move on to another patient, so there's no worry about carrying it from one patient to another. It has clot detection, foam detection, HIL, which is a hemolysis, icterus, and lipemia, so it knows that there's hemolysis on the sample, so then you need to have it redrawn. Like I said, highest volume testing per square foot as far as the size of the analyzer. Nice thing about it is maintenance can be scheduled to run automatically. Right now we spend about an hour a day doing maintenance on our current analyzer. This one will just do it whenever you program to do it in the middle of the night. Has onboard calibrators and quality control, which we currently have to put those on. This will already stay on the analyzer. Don't need to pause the machine, everything's on the fly, so right now if we pause, it takes about a half hour to bring it back up. 30-day onboard stability for reagents and calibrators. Quality control will run automatically daily, so right now we have to put it on the analyzer and run it, program it to run it. Has a big reagent load capacity, which we can run several tests at the same time. So the big thing is that the fast turnaround time and accurate results in the high sensitive troponin is what the doctors are really wanting. There are other analyzers that run it, but as you can tell, when we budgeted $275,000, and Abbott came in with a quote of $260,000, and then McKesson and Fisher had quoted me a Siemens analyzer, which they're about $100,000 more. A big part of that is the quality control. Currently, we spend about $130,000 a month or a year on a quality control product, and this is included in, because we'll be using Abbott controls instead of Bio-Rad. So, in all, our suggestion is that we get approval to purchase the Abbott Alinity at $260,600.
Did you say the $130,000 is included in this purchase?
Yeah, so we'd be using Abbott's
Okay.
quality control product
Okay.
versus buying it from Bio-Rad like we
Got
do
it.
now.
Jason, do you have another machine that you back up with?
We don't, no.
Was it a couple years ago we bought an add-on to this then? Was that?
No, we have what's called an iStat. It's a little handheld that we can run like a basic metabolic panel or a troponin. The iStat will not run the troponin, the high sensitive one, so we really don't have a backup for it. But we've really never had a backup to begin with, so.
Was our old machine being traded in then?
What's that?
Our old machine being traded in, or is it just going to?
It was a lease.
Lease?
Yeah, so it's gonna go away regardless, so. I've never been a big fan of purchasing chemistry analyzers just because things change so often, but this one, just with the way interest rates are, it makes more sense to purchase it than lease it, so.
Yeah, so So he went through a heavy vetting process with a couple other different analyzers just to, some are new on the market, don't really have support yet. That was one of the proposals is kind of incomplete because this includes an annual maintenance, so they'll come in and do PMs and everything also every year. Now, this was budgeted for this year, but because we've had several different repair projects that have kind of eaten up our budget for this year, we're going to put off buying it so that we receive it after July 1st. So it'll be out of next year's budget, but with kind of us jumping around a little bit and the time to get it ordered and get it delivered and stuff, we went ahead and brought it to you now, but it will come out of next year's budget because we don't quite have enough room in this year's budget for it.
Yeah, and if we tell them to ship it after July 1st, then it'll come out of next year's, because they won't invoice you until it's actually here, so.
So you mentioned something about like an annual maintenance contract or whatever. How long does that go? And is this machine like a 5-year life machine, 6 year?
Well, it's a 5-year
Yes.
maintenance contract, so the first year is under warranty, so you don't pay maintenance. But then after that, it's, I don't even know, it's like $13,000 or $14,000 a year to maintain it, so. But the nice thing about this is everything's hands-free. I mean, I can put everything on, it eliminates a lot of tech time. Like I said, we're spending an hour a day with maintenance. Now when we do monthly and quarterly maintenance, it's probably, 4 or 5 hours to do all that, so. It's just, this will all, you program it and it runs it, and you don't have to worry about it.
Make a motion to approve that purchase of the Abbott analyzer.
I'll second that motion. We have a first and a second. All in favor?
Aye.
Opposed? Motion carries.
Thank you.
Thanks, Jason.
Thanks, Jason. All right. Next, we're going to go with Jeff here. Consideration approval of construction manager for the renovation and expansion.
Okay, construction manager, once you're aware, they're a professional service that provides the project owner with effective management of large projects. They, no matter what our setting is, what the project is, they're going to be responsible to us in ensuring that we have a successful, on-time, on-budget project. CM represents our interests and provides the oversight of everything. Murray Company is our current CMAR over the emergency department project. So everything, they're responsible for everything on that, the budget, the change controls, the timelines, and coordinating all of the subcontractors and such. There is a process that the state passed in July of '22 to vet out construction managers at risk for public entities. That was not available prior to that. We could enter into a construction manager advisory, which then a construction manager would advise us on the project, but would still have to go with the design bid build with low bid process. So this allows us to bring in construction manager at the beginning of a project to keep costs, everything in line until we get up to ready to move forward with the project. They then provide that guaranteed maximum price that then we manage the project to. So the whole process to find the CMAR is we have to post on job board, a statewide job board for 2 weeks that says we are looking to post an RFP, RFQ process to hire a construction manager at risk. Then we send out the RFQ, which is a request for qualifications, and anybody and everybody can apply for the qualifications. We go through and have a process we score each of the entities on, and then we'll issue an RFP for a more detailed process. So we issued our RFQ. We got 3 respondents with Graham, McGuff, and Murray. All 3 were offered the opportunity to reply to the RFP. They had 2 weeks to respond. We took 2 weeks actually to score. We had a couple of follow-up questions we wanted to ask. And the scoring that came out is Murray had 80, Graham 73, McGuff 69. Quite an intensive process. That whole process took 2.5 months to get through. And with that, we would like to recommend that Murray be approved as a construction manager at risk for our rural health care expansion and remodel, along with the inpatient remodel and outpatient specialty remodel. So what questions do you all have?
I'm interested in how you score. I mean,
We have to post the scoring criteria as part of the RFP and the notice that goes out. So on the, I don't have the exact lines, but one of them was responsiveness to the RFP and the RFQ. But within the RFP also, we can ask pricing. What is their costs? How much for pre-construction services? How much is your percentage for the project? How do you envision timelines and managing the timelines, score on that? What is your past experience with Myrtue? What is your past experience with CMAR? Past experience with hospitals? Ask about the revenue streams, how much of it is healthcare versus non-healthcare. So you really get a good picture of how involved they are in medical, hospital, healthcare facilities, whereas do they have other entities, education or anything along that line, other industries. So we had, I think there were 12 items we scored the RFP to, and I think 10 on the RFQ. The RFQ, I mean, just the names alone, they're all qualified. So that was kind of an easy task to go through. Everybody got the RFP, but then going through the RFP, we did have some interpretation differences on some of the costing. So we sent a couple additional follow-up questions to get more detailed information on fees, timelines and such, so that it better give us a more detailed look at how they would manage a project.
Was there any area that Murray scored higher than the others specifically in?
Yeah, obviously experience with Myrtue. Actually, all three of them have a little bit, we've had some relations with all three. Obviously, Murray having 2 projects currently in progress, they scored a little higher on that because of known entity here on site. McGuff, they helped me in a couple conversations when the bill was just approved by the legislature before it was signed by the governor or went into effect. McGuff helped me understand what is the bill, what does it entail, how do you move forward with it. Kevin Tubbs at Murray also was instrumental in helping along that line. And we also had a couple brief discussions with Graham on that same process and what their offerings were. So past experience with Myrtue was the biggest points above that they had. For the most part, everything was pretty close in scoring. McGuff, I've found a few mistakes in their proposals, so that's why they weren't as high as what the others were.
How do we compensate these people?
It is based on the guaranteed maximum price.
Okay.
So
Is it the same level for each one of them then? They all get paid the same off that pricing?
For all 3 entities?
Yes.
No, it's different percentages for each one.
Okay.
So they charge a flat fee for pre-construction services.
Okay.
Then it's a percentage off of GMP that we would pay them to manage the project. They have construction, all of the equipment that comes in for the job trailers, the support equipment and tools that they bring in to work on the project. They also can do self-performing work that they would, if they can do the work, then they get paid for that. So, but it's all based on the GMP and the amount of work that is going to be required.
Does that factor into your RFP then?
Yes, yes
Okay.
it does. Yep.
How did they compare? Can you tell me how they compared to each other,
Sure.
pricing wise?
Yep, so Murray had 10,000 construction fees, Graham had 10,000 construction fees, and McGuff had 25,000 construction fees. Get down to the percentages, overall, Murray had 6.35%, Graham had 7.3%, 3%, and McGuff was over 9%, based off their GMP.
Awesome.
Any other questions? I would need an approval to move forward with Murray as our construction manager at risk.
I'll make a motion to approve Murray as the construction manager for the project.
I'll second.
First and a second, all in favor?
Aye.
Opposed? Motion carries.
All right, thank you.
All right, next, we got Barry with the CEO report.
So I'm going to focus my report on the master facility project, the rural health clinic, med-surg and specialty clinic. So I did send this out in advance, but it's been tweaked a little bit, so this is a little bit different than what you received yesterday. I did want to just start with the kind of a little bit of the history again, and I'm not going to be able to read that very well, but the board did approve architectural contract for design of the RHC East expansion back in January of 2020. That was after about 3 years of planning, and at that time it did include a second floor for behavioral health. Then moving forward to May of 2020, we did delay that project indefinitely due to the pandemic. And around about that same time, we did move the behavioral health department to the larger building that they're currently located in. Significant increase in space when that happened. So we fast forward to 2023, spring, summer 2023, we felt like it was time to start discussing that project again. Ended up contracting with Altus Architects in Murray to do a master facility plan, which they completed that in January of 2024. So moving forward then, at our February 6th board meeting, we presented a proposal to get approval for the design of an east expansion for the rural health clinic, as well as some work to be done on the med-surg unit and also specialty clinic areas. And that was estimated at 12.1 to 13.1 million at that time, not including any equipment. So that's been our last discussion. Since then, we've had the architects and our construction manager working on the schematic design, detailed design, and leading us up to where we're at today. And so this is where we're currently at with our med-surg design. It hasn't really changed much from what we presented to you in the past. This is the current nurses station. That has changed a little bit. We do want to open that nurses station up so it has better line of sight to these patient rooms that are just right, I guess, on our, what you would call our west wing, along with those rooms right across from the nurses station. So we're basically having to move a supply room from right in this location to right here. And then we're focusing on these 5 rooms. We are looking at this room as a bid alternate, and that would be a bariatric patient room. And that's really the only, I think our understanding, Dwayne, and you can tell me if I'm wrong, I think that's the only room that we were able to do a bariatric.
That's correct.
Bariatric room. So we're going to bid it out as an alternate when we go out to bid on this. So that's where we're at with med-surg. Not a lot of changes there. Specialty clinic, a big focus on what is now cardiac rehab and changing that into more exam rooms. We think that's probably going to be where Miller Ortho works out of. Cardiac rehab will move to the current emergency room, temporary emergency room area, which opens up quite a bit of space for us in the specialty clinic. Also going to do a little bit of work on the reception desk and some of that work area behind the reception desk. This has been kind of tweaked down quite a bit from what you probably saw initially, but it helps us expand specialty clinic by moving cardiac rehab. We don't really have anywhere to expand to with our current specialty clinic, pretty much landlocked. So that's a way to take existing space and make it usable for our specialty clinic. We're also talking about moving some of the specialists over to the rural health clinic, which gives them more ability to grow moving forward in the specialty clinic. So this is the rural health clinic, and the green, this green space, that's the expansion. Everything over here is our current main floor of our rural health clinic. So this is based on a one-story expansion to the east. This up here, this darker green, is part of the existing clinic, but we will have to do some work on that in order to be able to expand into this new area. Basically flow of patients over into this waiting area. So that has to be done as a part of this project. The red areas are going to be an alternate. We'd like to do some work in the existing clinic in these areas, but we want to see what the cost of that would be. So we'll do that as a bid alternate as well. This space down here, this is for kind of an enclosed staff entrance, as well as the ability to move from the new expansion to the existing clinic. We would make a walkway through there.
Is that the existing door that they use now, right there?
That's from the outside?
Yeah.
Yeah, yep. So we've just enclosed that. And you guys can jump in, and Dwayne, if I'm missing something here, and then the light green is just areas where they will have to do some work, because there's windows that will get pulled out of that area. Basically, that's window and paint, I believe, is what this really light green area is. So that's where we're currently at with the design. I don't know, Dwayne, do you want to add anything to
I would just
those
say,
three areas?
I would just add, as part of the addition, the functional space is 24 exam rooms, new exam rooms, with support space between kind of the two pods. There's two real pods there, and then for providers, 10 offices that are kind of aligned on the south end, as well as a break area for staff more to the west of that south facade. I think it's 14,000 square feet, right around 14,000 square feet of just additional space or new space. And then, like Barry mentioned, that dark green is more for tie-in back to that main entrance.
So this is what we've gotten approval from the board for to date, is the design of this area, as well as the specialty clinic and the med-surg area. So we're gonna kind of switch gears here just a little bit, and I'm not gonna ask the board to approve anything today. I think as we move forward, you'll see there's a lot of new information, and I think we need a little bit more time to kind of digest what we're potentially gonna be proposing here. But just to switch gears a little bit.
I just have a couple of quick questions, if you can go back to that. So there's still going to be providers in that left section then, right?
Yes.
And tell me how we're going to get me there. How am I going to get from that reception area?
From this area?
Yep. Same way?
Same process. Yeah, so you'll go down the same way into this existing area that you do right now.
Okay.
And getting over to the new area, this will all be waiting, will be connected to
So
this
not
area.
all the doctors are moving to the new space. There's some that will provide.
Some will stay over here, some will move over here.
Okay.
The intent is to move all of the family practice down from the second floor down to the first floor. And then we would use that second floor for specialists.
And this is going to
That's-
sound really dumb. Do you think it's going to be hard for people that are in the specialty clinic to move, like have half of those people here and some here? And like, as I'm a patient, I think about that. Like, do I know where I'm going?
Yeah, I mean, we'll have to do a good job of communicating as we're scheduling patients with our signage.
Okay, that's something I worry about. And then like getting lost in there and then floating around and people grabbing
Yeah.
me.
Yeah, we'll just have to do a good job of communicating that, I think. So this is listed as a financial opportunity of a combined RHC behavioral health. I'm going to have Christy talk about this a little bit. Maybe it's a little bit more than just a financial opportunity. It's also an opportunity to bring rural health clinic or behavioral health more integrated into the rural health clinic to a degree. So with that, I'm going to let Christy kind of talk about what we've learned. I guess we've learned this just in the last month or so, which throws a little bit of a curveball, but I think it's a good opportunity. I'm glad that we're finding out about this now instead of 3, 4, 5 months down the road, because finding out about it now, we can do something about it and take advantage of it. So go ahead, Christy.
So our previous to January 1st, Medicare did not recognize licensed mental health counselors as being a qualified provider to provide Medicare services and bill as an individual. So the only way that you could bill for that service in a physician's clinic would be to have them see a doctor, in an RHC I should say, a doctor the same day, and you're still only then billing for one service. So January 1st, they changed that to recognize if our mental health counselors are licensed with the state, which all of them are, they're recognized as qualified in the RHC to provide services. It took until the end of November, or excuse me, the end of March, basically, after that regulation come out, is when CMS, they issue a regulation, and then you've got to see how does it apply to PPS hospitals and how does it apply to critical access and rural health hospitals. In the end of March, they recognized that we could move these providers into a rural health clinic and get reimbursed what they call our AIR rate, which is we get paid an all-inclusive rate for each visit that we have for Medicare and Medicaid. And their goal is to increase out here in the rural communities access to mental health services. So with that being said, it would be very difficult to take that away down the road. I know that's kind of a concern, but I do not believe that once they implement that and the way things are in the world today, that would be something that they would go back on. And it also allows for us the opportunity to have growth in our reimbursements for Medicare and Medicaid patients. Commercial plans don't care. They'll pay for it in a rural health clinic the same as if it's not a rural health clinic. You go to the next slide, okay. So basically, just to kind of try and, 2 years ago, the CMS gave us a cap as to, okay, they're going to increase the rate we were at that point, so our cost per visit that we had at that point, they're going to increase that by inflationary rates each year. And if our costs should go higher than that, which are workforce shortage and provider shortages, we're not always. I mean, the cost of living doesn't. We go up higher quicker than the cost of living goes up. So we would get to where our costs are more than our cap. Well, we're not getting reimbursed the difference between those. So by pulling in the 12,005 visits that behavioral health has, which are at a lower cost per visit, right now they're at the point of our last cost report, we're $187 per visit. So at the RHC, it was $292 per visit. So you add those visits to that, it brings our combined cost to $267. So therefore, our cost is down here and our cap is up here, so we have room for growth. in expenses, which if we build a building, there'll be depreciation, and so automatically, our expenses will go up. So we'll have the opportunity then to be reimbursed for the cost of that building over time.
The 122, Christie, is what we're.
The 122 behind that is what we get reimbursed now,
Okay.
on average for Medicare and Medicaid patients. So our reimbursement for behavioral health would go from $122 up to that $267, and as that grew, but our rural health clinic reimbursement will go from $292 or $301 this year with the inflation down to that $267. But that drop is much less than the increase we're going to get for behavioral health. So it nets out about a $900,000 annual increase in our reimbursement for Medicare and Medicaid patients. So that makes the ability, that makes it more favorable to invest the additional capital into bringing behavioral health over here.
One thing I wanted you to point out is that it has to have the same physical address. So you
Yes.
can't get reimbursed when it's in a separate building. Correct. With a different physical address.
And we've even talked about, where we place the entrance to get the patients into this new area, and we really need to make sure that we stay with the address that the rural health clinic has.
Is the reimbursement rate different for when you go in the outpatient doors and when you go in, that's what I thought. So,
Yep.
okay.
So they would enter the main door and ride the elevator to the second
Well,
level?
would probably be you could have, in my opinion, yes, that's where they need to come in, is come in a regular door. They need to come in off of Chapman. So if you go to the next slide. So that's the reimbursement effect of it. Okay, so we have another slide.
I think that's it.
Oh, so did you put the debt one later then?
That's it.
Okay.
We'll get to that.
So that's is there any questions on it? It's kind of confusing how they reimburse us and everything, but it is, we've worked through our cost report, we've worked with our auditors, we've confirmed that they're recognized by the state, so it is a pretty substantial increase in our reimbursement.
The 12,005 behavioral health visits, that's annually?
And of that, 4,881 is Medicaid and Medicare is 2,108. And Medicaid in a rural health clinic is not limited to the cap, it's actual reimbursement. And that's not the case in any other area of the hospital. They give us our rates based on last year's cost report, and then the next year they'll update them, but they don't go back and reimburse. But in the rural health clinic, they do. So that is a big advantage when they have such a high Medicaid volume.
So yeah, the annual potential, I think we're estimating between $900,000 and $1 million of additional reimbursement as a result of combining behavioral health into the rural health clinic. Right now, we've organizationally made a decision to put a lot of resources towards behavioral health. They lose money right now. They do lose money, so we are subsidizing that area right now. So this is an opportunity for us to get that more close, I think, pretty close to a break even. This $900,000 is not just about behavioral health, it's also supporting the rural health clinic as well. So the reimbursement within the rural health clinic is better as well. So it's a combined benefit of between $900,000 and $1 million. So what I want to present is some options for us moving forward. There's 4 different options. The first option you've already seen back here. Options 2, 3, and 4 are kind of right here. I guess I'm going to have to explain this. And Wayne, you might be able to weigh in, or Jeff as well. But So this is the second floor, current second floor of the existing clinic. So one of the options, so option 2 would be to move the rural health, move behavioral health into the second floor of the rural health clinic. Basically would have to gut that area and redesign it. Some of the things that we don't like about that is, what our goal was, as part of this project, was to move some of the specialists over into this area. And obviously that would eliminate the possibility of doing that. So that's one of the downsides of moving it into this location. I think there's about 6,400 square feet. The current behavioral health area is about 5,700, so it would give us a little bit more square footage, but maybe not as much as what we would like, going into knowing that we're spending quite a bit of money to do it. So if we're going to spend those dollars, we'd like to get more square footage than 6,400. So that's option 2. Option 3, and I'm going to get to these options here in a second. Option 3 involves building a second floor onto the addition of about 7,500 square feet on the east side of that expansion. And that's option 3. So both of these options takes advantage of the financial part of combining rural health clinic or behavioral health into a rural health clinic. Both of those options, 2 and 3, accomplish that. This option's an additional about 2.3 million. This one over here is about 5 million. And I'll show you those numbers here in a second. With the $900,000 to $1 million in annual additional reimbursement, that's a pretty good turnaround, return, payback period, I guess you could say. So 2.3 million over here and about $5 million over here. Of course, if we do this, we open this whole area up for specialists or potentially family medicine doctors, and it gives us a lot better opportunity for growth moving forward. The fourth option would be to shell, to do the behavioral health addition on the second floor, but then shell out the rest of the space. So essentially we would be building a 2-story addition, 14,000 square feet on each floor. And that's about it's an additional little over $1 million cost to do that. So did I miss anything, Dwayne? I'm going to move into kind of what some of these options.
No, I think you captured that. I just wanted to clarify. I think option 2, and tell me if I'm wrong, option 2 doesn't include building above the rural health addition.
That's correct.
That's correct.
Right. So that would be no second floor.
Correct. We would design for a future second, but it wouldn't be done under this scope.
Right. So then to clarify that a little bit better, I kind of tried to already explain that, but estimated cost for option 1, which just 1 floor addition to the east, also includes specialty clinic and med surg. We're looking at 12.8 million to 14.2 million. Pros of that: it meets the needs of the rural health clinic, family medicine, and specialist growth needs. The downsides is we're not taking advantage of this $900,000 reimbursement area regarding behavioral health. We're not doing anything different with behavioral health. They would stay over in the building that they're currently located in. Option 2, we do the east addition, and again, we're taking the existing second floor of the rural health clinic, converting it into behavioral health. And that cost is $15.1 million to $16.4 million, about a $2.3 million increase over over this, the first option. Again, the advantage there is that you are taking advantage of the rural health clinic reimbursement, behavioral health combination reimbursement. Cons, it limits our ability to move specialists over, so it limits our specialist growth into the RHC. And there are some pretty good financial advantages in moving, for example, the OBGYN as well as the general surgeon, moving them over to the specialty clinic moving them over from the specialty clinic to the rural health clinic has some financial advantages as well, along with several of the other specialists that we could potentially move over. Parking is going to be an issue on option 2, 3, and 4. And that's an area that we got to figure out over the next few weeks before the next time we talk to the board about this. That's something we've got to figure out on all of these options. And then option 3, again, is we build a second floor on the east. We do the east addition to the rural health clinic, and we build a second floor that's 7,500 square feet for behavioral health. Estimated cost there is, I can't read those numbers, 17.8 million to 19.5 million. Again, that option, reimbursement of combined RHC and behavioral health, allows for more growth. Obviously, the cons, we get into cost, is a higher number than what we would like. And then parking, option 4 then is where we do the second floor addition and shelf. 14,000 square feet on the first floor addition, 14,000 square feet on the second floor of that addition. Some of that being shelved space and some of that being behavioral health. And that gets into 18.7 million to 20.6 million.
And those numbers are with those, without those add-on pieces, like that bariatric room stuff. Is that correct, or is that in these numbers?
That would be in these numbers.
The bariatric room is?
Yeah,
And
and
then
then
like-
surge piece would be in that.
Yeah, the
correct?
bariatric room was an add-on, is that correct?
Yeah, I don't think that's included.
So that's not included, that room is not included.
Okay, but then the other ones that you talked about that were add-on ones, they're all rolled up into these?
Yeah, so we did a range, like on that option.
Not the add-ons. Add-ons won't be.
Well, the one was. That's what you
Yeah.
said.
Med-surg firms?
That surge is
I just want to be clear
1.7.
what
Okay.
we're looking at, I guess.
So
Add-ons are not.
this is included in,
Oh, so what are you saying?
because we're giving you a range on the cost.
Mhm.
So the lower end of option 1 range does not include this, but the higher end does.
Okay.
Okay. I think some of the other things that are included, it also, the higher end range on option 1 includes finishing all of these other, updating the finishes on all of the existing exam rooms and doctor's offices in the existing clinic.
Okay.
First and second floor.
First and second floor.
Option 2, right? Is that what you said?
I know this gets a little bit confusing.
There's just a lot
with
going
these
on.
different
I think
options.
all 3 options includes the updates to existing offices and exam rooms.
Okay.
The high end does, and the
The high
low end doesn't.
Yep,
so.
no, that's why I'm asking.
Yeah.
So then on the other one, do you have pictures of what that looks like between option 3 and 4? It's like where you're gonna put the one on the east side, but then not have the shell built out?
Well, we've got an exterior.
Yeah,
Is that what you're saying?
yes.
Yeah.
Okay.
Because I think that might look weird, wouldn't it? If you got like a clinic with a second level and then a big space and then a,
We were gonna do some natural lighting and stuff,
So-
Terry, weren't you? Natural lighting and windows.
Well, we're not looking at doing the natural lighting anymore. We can't do that and still be able to go to a
the way I
second
look
floor.
at that option 4.
So Dwayne, do you want to explain these?
Yeah, I'm gonna come over here, because I'll hold the point.
what's option 3 where there's like down there? Is it like there's a gap between them?
Yes.
Yeah, that's where I thought the next one
Okay.
would come in, but,
So
That's what looks weird.
those top two elevations are the south elevations, so that, these are what you would see from Chatburn up here. This one here shows the full build-out of second floor, and this one here shows this area that's not built out here.
So that gray, the lighter gray is no build out.
That's open, and these are rooftop units up here. And because of this not going here, we wouldn't want to place a rooftop unit here in the event that you elect to do this in the future. So this one here is shown as a little bit larger to serve not only second floor, but first floor down below. So that's why that one's shown a little bit larger there. We can handle this up here in this same manner instead of doing two. We just haven't arrived at that yet, but we know if we leave this open between the new addition and the existing, that we'll do something larger above that.
And also on that, if we, without the shell space, whenever we decide to build in that area, what's underneath will have to be closed for a period of time while they do the heavy construction, lifting steel, and the concrete and all that. That space below would have to be unoccupied while that work is being done.
If we did
If we
the
did
natural light, if we did the clear story.
No,
If we didn't do the shell.
if we don't do the shell,
Oh, okay.
yeah. Then when it comes time to expand into that space, whatever underneath it will need to be closed for a period of time.
That's option 3 versus option 4.
Correct.
And then these are just,
So like that.
this is the same image looking from the east, and then this one's from the north. Those two elevations would remain similar. It's really the south elevation that's different in those two options, 3 and option 4.
And those would be windows then, like on that on that top one? Between those?
This one here,
Yeah.
right here,
What's that?
That's essentially some of the area that we're looking at along that south side, which would be office space, that break room area along the south facade. And again, these are just kind of iterations. This was a first look at what this could look like, might look like.
I definitely like that top one better. I mean, I just think it makes it look like it belongs there.
This one gives you more balance
Yeah.
with that whole massing. This one
That looks weird.
tends to be a little bit unbalanced when you look at the facade.
and on the back side of this one, this would be a walkway to get from the elevator, which is approximately here in the existing building, to walk over to the north side where the reception would be for behavioral health.
And both of these options, 3 and option 4, would integrate 2 new stairs along that east addition, the very far east addition. However, no new elevator. We would be utilizing that existing elevator in the rural health clinic to feed this second level.
So the high end though on those options did include an elevator on the east side. And so we haven't determined whether we would need an elevator yet, but it's possible that we may want to go there, may look at an elevator, or if we decide to have the entrance for behavioral health on the east side, we would definitely need an elevator then. But that's figured in on the top end of those price ranges.
So in the option 3, option 4 scenario, you go to the option 4, you're really going to need that elevator at some point if you occupy all of the space.
I would think so.
That's something we've talked about. And if we did do that, under these options, we're still looking at using the main entrance for behavioral health and access to that second floor. We have kind of studied what it might look like if we didn't do that. And that study kind of included an elevator. I don't know if that was in this price.
It's, like Barry said, it's part of the range.
in the company options right there.
We really have to confirm whether or not that changes our reimbursement, so that's really kind of why.
The entrance.
The entrance thing, right?
Because it's,
Funny how address and entrance can affect such stuff monster.
That'd be on 12th Street.
So the other thing I'll add too is, as we start approaching the east with the addition, we run out of sight, right? We're coming to the very far east of the campus, and really integrating any kind of entrance at that side is limiting us with parking. So we kind of looked at it and explored it earlier on, but it seemed like it lent itself to still utilizing that main entrance. And then I think utilizing the address of the hospital was something that we needed to do. So that's kind of the direction that we headed under these concepts.
Would this allow you to have parking then still on the east side there also?
We would have some parking over on the east side. I think we allocated about 84 stalls. We would lose about 16 stalls, so that total is 84.
And that's not
with
still enough?
Developed parking.
The east and the south of the expansion, that's the 84 that you're, well, and the south of the existing rural health clinic along, yeah, that's 84, right?
Options 2, 3, and 4 is the con is parking. How much total space do you give up on 2, 3, and 4 in parking? Was it 16 or was it
There's
more?
16 current spaces that
That's
are included in that 84.
Okay.
Right.
But you're also, especially with 3 and 4, you're adding space. You're adding more
More square
building
footage.
space, more square footage, which
Yeah.
requires more parking.
I get that there's more offices, potentially more people, therefore more parking needed, but, you know, yeah, how does that going to get solved? That's a good question. I mean, you pretty much run out of real estate unless you go more vertically. But.
Well, I think we're going to look to the west side of the property. I mean, obviously, we're going to want patients to be able to park as close to the entrance as possible, but there's still some things we think we can do on the west side. So that's what we're going to be working on here over the next couple weeks.
That's a lot of options.
Just to, and I'm going to ask Ken and Major to talk about this a little bit, the soil remediation. Maybe just have you guys, Major, I don't know if you want to address the issue with the soil, where we're planning to expand to.
I'm going to throw a curveball at you, and I know by surprise, but I promise it's a good one.
Okay.
So, Barry, we sent Barry and Jeff an email this morning with the information we had at the time, and then we got some additional information, which is good. So, I'm going to use this to demonstrate what we have going on. So, if this is grade as we see it right now, yes, it does slant, but straight lines are nice and easy. We got a new soils report about 2 weeks ago. We've investigated that with the design team, structural engineer, civil engineer. What essentially it's telling us that we need to do is there's poor soils and there's some rubble. There's some old debris from old construction. I think there was an old restaurant, old gas station, and some of that's below the surface, and we can't build on that to have a good foundation because our dirt is our true foundation. So they're saying we need to go down 15 feet and remove all of that dirt, get rid of about 2,000 cubic yards of it, do some special soil stabilization, and then build it back up. And then we have to build our grade up because we have the slant site. That we accounted for in our original budget, the budget you see today for the first floor rural health clinic, we accounted for about $500,000 of soil remediation because we got a previous geotechnical report. So we had a fairly decent guess. Worst case scenario, in talking with SM Henches, who's done all of our site work right now, our earthwork contractor, we think that the high end of that, based upon what we know today, is around $900,000. So that's a delta of about $400,000 that would increase the current budget. However, based upon experience, some conversations with the geotechnical engineer and our site work contractor, we think there is an option that exists. It's really technical, but we think it gets it back to within that $500,000 budget. That's the part you didn't know, but we found out in the ride over here today. So we want you to be aware of the risk. We think the worst case scenario is an additional $400,000 to fix this, but we do think there's some strategies that could lessen it, if not get it back to where we currently sit.
You're expecting that there may be surprises when you start everything?
That is the scariest time for you as a client and us as a contractor, because it can be hard conversations. We can't see what's under there. And until we excavate it and open it up, we don't know. My biggest fear is that was a gas station, was it taken care of properly? That is a risk, and I want you to be aware of it. But we think right now, worst case scenario, if we had to muck everything out, we know that cost. We know that that gets us to about $900,000.
The original survey that they started with was done about 4 years ago, and they had drilled, I think, 2 cores out of the space that we were going to be looking to build at. We had them come back and evaluate, and we drilled 6 additional holes throughout the entire space, and so that's what really identified that there's rubble down past 6 feet deep, and there are other issues that are in there. So
the other piece that's impacting this soils report, we've got one, just what's there, and then the other piece is as we explore maybe going vertical, having this second floor, we're obviously having more load, more weight, and that has a cascading effect below. So that's incorporated in these numbers we're talking about. Is we're looking at this as we're preparing, whether you choose to build a second floor or not right now, we're preparing the earth and the structure for future expansion in our base number. If that makes sense.
I guess the other part of this is we would need to do this fairly soon, or we would need to start this probably within the next couple months, prior to the point where we had, we want to start the building construction in September, and that's what we've talked about as far as a timeline, but this would have to probably start in June, July timeframe.
So ask lots of questions here if I don't explain this well. Feel free to beat me up. Yes, Barry's 100% right. If starting this year is still a priority, there is a pathway to do that. It's probably, I wouldn't say it's untraditional. It's something that Altus, Murray, we do all the time. It's just we have a couple different divergent pathways that are happening. We have enough information right now, and we can get there within the next probably month to say we can quantify the amount of soil we need to do and what work needs to be done. We basically, if the rural health clinic's a project, we take a piece of that project and we need to perform that early. Design still happens in the background, but that allows us, we have to import this dirt, let it sit and monitor it for 4 to 6 weeks to make sure that it's properly settled, because your true foundation is the dirt. So that allows us to start that work early, where we can quantify it, bid it out, have 100% certainty, because we can get that piece designed now, while the rest of the rural health clinic, behavioral health options, those are still being designed. But no matter what, if you want to build a daycare center here or a new surgery, whatever, you have to do this part to remediate the soil no matter what you build here in the future. So we would get that building back ready and have a new MRI entrance and a few other things. There's some utilities that have to move. But this sets you up for success in the future, no matter what you choose to do.
So regardless of which option is chosen, the soil remediation has to happen first, either way.
That's correct.
So would you remediate the entire area, or the area that you're going to dedicate to parking? Is it necessary to remediate that?
The parking doesn't carry the same kind of load that the building does. So we're really looking at the footprint.
The footprint of the building.
That 14,000 square feet, that's what we're good. So that's where the geotechnical engineer is concerned.
So from a contracting standpoint with Murray, the construction manager, and this is this is the way I'm understanding this could work, is that we would have a contract with an initial GMP, guaranteed maximum price, for just the soil remediation because we know that has to be done no matter what happens moving forward. And then when we get to the point where we approve the full GMP, the board approves the full amount, we would amend that contract to increase it to what that full GMP amount is. So what I would be anticipating doing in the next month or so, or possibly even if we have a board meeting, say in 2 weeks, which is probably what I want to recommend, is that we have a meet again in a couple weeks to determine where we're going with this, final decision on how we're moving forward. At that point, I'd want to get approval for a contract with Murray with a GMP only for the soil remediation at that point. Does that make sense?
I'm just going to ask why we're waiting on that, just because we already, in previous board meetings, we've already approved that first floor addition in any case.
You've approved the design work. You haven't approved the building
Right.
project yet. That will come, our intent was to do that in August. The full project, the full cost, that would require a public hearing as well. So really all you've approved at this point is the design work of that first floor along with the specialty clinic and med surg.
Do we need a public hearing for this, for the soil remediation?
I think we do.
Well, then we do have to be, that's where I was going.
$500,000 to $900,000, so yeah, we would.
Yeah, okay.
Hey, Barry, I do not want to muddy the waters, but I want to manage expectations. So, because we're looking at 500 to 900, that's just for the soil work. So in order to do that properly, this is easier if we're all looking at a picture. But the new MRI drive has to be bored so we can maintain continual access to your MRI machine, right? So once that would be included in this cost of work. And then we have the removal of your existing drive that runs north-south. That would get removed. We'd have to remove some utilities. Then we could do the soil remediation. We haven't quantified that. That's what we're working with Dwayne on to do next. We're looking to have that here within the next week or two. The number's going to be larger than that 900,000, but it's a piece that but your rural health clinic costs would reduce because we're just taking that on earlier. If that makes sense. I just didn't want to surprise you with here's a $1.5 million job. You're still getting it, you're just getting it earlier.
Definitely needed.
Okay, that
Public hearing.
Okay, then I guess one other area, going back to Christie on some financing aspects of this, so go ahead, Christie.
Yeah, so looking at our lowest cost options now, we would be borrowing $1.8 million to do just pay option one. The highest cost option, we would have to borrow $9.6 million. This ensures that we have $8.5 million still cash on hand, which for critical access hospitals to be considered financially sound is about 60 days of cash on hand. So we would still maintain our sound financial position that we currently have with that $8.5 million. We've run through the different options. There's costs involved with the debt and stuff. So really, we need to get closer to deciding what option we want to look at and kind of what's the current rate of interest, and look at our finance options, because we get up there to that higher borrowing limit, we may want to look at a different type of debt structure than just a regular commercial type loan.
Are you going to narrow those options down for us so that we're not trying to pick from four?
Yeah, at the next meeting. I would propose that we have a meeting in 2 weeks on May 21st, and then we'll make a recommendation.
And we'll skip the 28th meeting then?
Yeah, I think we probably can not have that meeting. All right, that's,
Any other questions? We'll move on to Christie.
Hey, Christie, does that take into account that Medicaid money, is it Medicaid money that we're seeing now show up? That's into those, you factor that all in?
So for financial, I'm not gonna really, matter of time here, go through February's financial. It was in your packet. A good, strong financial month again, a little above break even, so year to date, we're at 1.5 million. So for March, you can see here, for year to date, for outpatient visits, we're up 6.6% for visits, up to about 43,375 for the first 9 months of this fiscal year. Our emergency room visits are up 1.1 to 4,310. Surgical procedures are up 6.7%. We're down over 1,100 surgical procedures here. Physicians clinic visits are down 2.6%. We're still close to 32,000 visits. Behavioral health, we're down about 5%, which is at 11,656. Our inpatient daily census for inpatient observation swing bed is down about 13.3%. We're down to 7.88 patients per day on average, compared to 9.09 last year at this time. Births are at down 15.7%. We've had 59 births here this year, 70 last year for the first 9 months. I think we got some pretty busy months coming up after we just met for budget the other day. So our revenues from operations are up 7%. Our expenditures are up 4%. And so year to date, from operations, we're at 1 million. I do want to mention that we did get $934,000 from our first Medicaid direct payment that came in March. And so that's why that number looks like what it does there. We're set to get the second one, Medicaid direct payment, at the end of May. So that really brings us more closer to our cost for Medicaid visits, more comparable to what we would get paid for commercial visits. We have our net non-operating, which is taxes and investment earnings, so we're at 3.1 million net income from all sources year to date. If you look at the balance sheet, you can see that our accounts receivable is a lot higher. That is as a result of this Change Health Care. We've gotten the funding in for payment of those accounts, but doing it manually, and we are down 2 staff members really in the business office. So Carter has been helping with posting. I don't know if all of you know Carter Bendorf. He is our intern for the summer, so he's learning a lot from all different areas of the hospital. So he's helping with trying to bring that down for us also. So that is why that accounts receivable really is a lot higher than what it should be. Any questions on the financial reports?
I make a motion to approve both February and March financial reports as presented.
Second.
First and second, all in favor?
Aye.
Opposed? Motion carried.
I was going to move the approval of the payroll and claims for February and March. Maybe you were ready for that, Mr. Chairman?
I'm ready, unless there was any questions on the claims or the listing that we had to read 2 months' worth. We're going to ask for approval.
I move to approve that.
Second.
First and a second, all in favor?
Aye.
Opposed? Motion carried. One more thing, Nurses Week. If you see a nurse, or thank them. We're appreciative of everything they do. They work with us 52 weeks out of the year, so we can at least appreciate them for one. So thanks to all the nurses. So I get a motion for adjournment?
So moved.
First.
Second.
Second. Adjourned.
Do we have a plan for Hospital Week next week?
Yes,
Is
we do.
breakfast, did you get your card?
What?
That's because you're an auxiliary member, that's why you.
You need to join the auxiliary.
Hospital Week is the 13th through the 17th, and we have plans for every day. Since this is our 70th anniversary, we're kind of doing a decades type of a theme for the week. Or we might dress up, and one day it's 50s Day, one day it's 60s Day. But we're gonna have ice cream one day for the staff, we're gonna have a food truck one day, we're gonna have Dad's Belgian waffles here for breakfast on Wednesday. Some pretzels one day, and popcorn from the movie theater uptown. We'll have pop tours all week, so the first graders get to come and tour. So, lots of plans, lots of eating. Some food.